So thank you very much for inviting us, the HIV in Europe initiative, to allow us to launch the HIV testing week in beautiful Lisboa. I've been here when the sunshine is up. Now it's raining. Tomorrow it will be sunshine again. My brief talk here will deal with presenting the initiative and some of the focus areas that we have had, and then I will pass on the chair to Brian West, who will explain in more detail what will actually happen during the next week. This initiative was started in 2007 for the core purpose of ensure that HIV positive people enters care early in the course of the HIV infection than what is currently the case. And we want to, and very importantly, to stock up different stakeholders to address this aim. Not only clinicians such as I, but also patient advocacy groups and policymakers. We have had very successful biannual conferences which have galvanized the scientific community in pursuing this aim. So the objectives is to highlight the rising number of people living with HIV in Europe who's unaware of the zero status, to identify political, structural, clinical, and social barriers to achieve optimal testing and counseling, and therefore earlier care of HIV and AIDS. And finally, to promote public health best practices and guidance found in Europe with regard to HIV testing, counseling, and care. This is what we are trying to achieve, and this is what we have been working hard on for the last several years. The initiative is structured with a steering committee with representatives from patient advocacy, policymakers, health professionals, and European public health institutions, such as the ECDC, WHO Europe, etc. We have a three-party secretariat function where operations are dealt with out of my office in Copenhagen, policy out of the HG office in Brussels, and finances out of AIDS funds in the Netherlands. As mentioned, we've had now 3 conferences, and I'm happy to announce that our next conference will be taking place in Barcelona from the 5th to the 8th of October next year, and I hope to see many of you there. The situation has already been outlined, and it is very, very serious. 2.4 million people are living with HIV, of which around 1 million is in the European Union and 1.4 in Eastern Europe and Central Asia. And as also mentioned, 30 to 50% is unaware of the HIV infection. And in Europe, the epidemic remains concentrated on the key affected populations, including men who have sex with men, injecting drug users, sex workers, migrants, and prisoners. Although I have to say, I've been traveling a lot in Eastern Europe, and I see an emerging heterosexual transmission outside of these key affected populations in that region, which is extraordinarily concerning. The number of new people who is infected with HIV each year has been fairly stable in Western Europe, whereas, as you can see, the numbers in Eastern Europe are progressively increasing. What is even more concerning is that whereas the number of people who gets diagnosed, not only those who's not diagnosed, but those who actually gets diagnosed, that number increases faster than our ability to get people on antiviral treatment. So at the moment across Europe, we are behind the ball, so we get more people who's infected than those that is actually placed on therapy. Needless to say, that result in a lot of death. We estimate in 2012 that around 100,000 young people died from HIV across the continent. Around 80 to 90% of these deaths are preventable had we had effective public health measures to prevent that. The problem is clearly more serious in the eastern region, where the treatment cascade only suggests that around 10% of those infected, 10% out of the 1.5 million is actually on antiviral treatment. So needless to say, that's where most of the spreads therefore occurs. And it really speaks to the fact that treatment can both prevent and secure health for the individual person who's infected, but equally well get people into care and therefore reduce their ability to forward transmit. As already mentioned as well, we recently published a paper in PLOS Medicine that shows that even in Western Europe, we have not been able to deal with the situation effectively. Around 50% of people enters care across Western Europe with a CD4 cell count of less than 350, a time point in the course of HIV disease where we clearly should have started therapy before that. So therefore, these people are entering care too late and therefore is not enjoying the full benefit of treatment for their own health. Coming late into care and getting people on treatment at sufficiently high CD4 cells is really bad for your health. This is a modeling exercise of a 30-year-old homosexual man who got infected at the age of 30, and the prediction is, depending on his ability to get into care at reasonably high numbers, you'll see that around 10% of these people will be dead 20 years later. But if they come into care late, that proportion doubles. So this is a serious situation for the individual. Immune deficiency is clearly not beneficial for your health. So therefore, late presentation delays access to antiviral treatment, adversely impact on the health of the individual, who also are allowing inadvertent onward transmission. And it is clear that the solution is more effective strategies to test more effectively and ensure better access to care for those who's actually diagnosed. We know a lot about what is a cost-effective way of screening the population for HIV. We want to identify the sections of the population where the prevalence of HIV is at least 0.1 to 0.2%. As long as we are testing populations and we have that testing rate of positivity, this is a very, very cost-effective intervention. What we are challenged with, on the other hand, is that health policy in Europe is defined by the national health policies, and therefore each member state defines their own health policy. And therefore, European health policy consists of developing a shared competence with member states, which can then complement the national policies. As a reflection of that, there is large variation in HIV testing recommendations, and only a few countries have a policy of normalization of HIV testing, for example. And there's also tremendous variations in access to testing, care, and treatment. We know very well how to do effective testing. You can either self-refer, you can select clinics in the health system, infectious disease clinics or STD clinics. But it is clear that we need to have new and innovative ways of approaching testing. We need to build up community testing, although at the same time, in those community test centers, we want to ensure transferal of those who is infected into care. And the newest that we are heavily promoting at the moment is provider-initiated testing, where you essentially have health professionals do test in people that present with certain indicator conditions, such as mononucleose-like illness, TB, viral hepatitis, etc. There is a lot to be said about normalization of HIV tests. The research that is now coming clear is that the offer of an HIV test is acceptable to patients in many settings. For example, 83% of people that present for acute medical care actually accept an HIV test if it is actually offered. But the problem is that it's not very frequently offered, not even in cases of clear indications such as people with tuberculosis. There's high variability between clinicians in offering HIV tests, between 50 to 90%. And this really points out a lot of missed opportunities of HIV testing by the health systems. And we are good at this if we look at one particular situation, namely antenatal screening of pregnant women. Across Europe, we are very good in testing pregnant women. So we can do it, but we clearly is not doing it effectively and for the variety of conditions where it should be done. We have developed guidance on how to implement this across Europe that was released last year, and I hope that many of you have read this document and is seriously considering implementing it if you have not done already. So in conclusion, there is a clear rationale for HIV testing and timely treatment and care, of course. This to reduce mortality and morbidity, to reduce the onward transmission of HIV, and lessen the economical burden to the health systems, because we know that people who enter care late actually cost a lot more to the health systems than if you get people into care earlier. Not only because it is costly to treat the opportunistic diseases and all the morbidity that is coming with late presentation, but equally because you are then getting, if you get people earlier into care, you are preventing more transmissions, which is costly to the society as well. Barriers to HIV testing may exist at 3 different levels: at the patient level, the healthcare provider level, and at the institutional and policy level. And I think we need to work on all 3 fronts if we want to improve the situation in the years to come. Populations at high risk should be targeted with focused interventions. National HIV testing guidelines should be implemented. It should take an ethical approach based on human rights principles. And of course, training and awareness raising is crucial in order to normalize HIV testing in the healthcare system, for example, by implementing indicator condition-guided HIV testing, as I showed you. Laws that jeopardizes HIV prevention efforts should be abolished. And I really mean that there is a lot of public health policy across Europe that absolutely makes 0 sense if we want to tackle this outbreak. Monitoring and evaluation systems should be, of course, implemented, so we continue to build our strategy based on evidence and good common sense, as opposed to the spirit of today. So we have formulated a call to action for the next couple of years. We want to monitor and share research and best practices on HIV testing standards in order to improve practice and policy in this area. We want to stimulate the scientific development of activities and events to inform the European agenda on optimal testing and earlier care, and the HIV Testing Week, of course, is one example of that. We want to review data and studies on the impact of counseling and HIV/STI testing on risk behavior and support a consensus process to agree on optimal counseling practices. We want to facilitate the implementation and assessment of HIV indicator condition-guided testing. We want to stimulate an evidence base on and reduce barriers to testing that includes human rights, stigmatization, decriminalization, and discrimination. We want to continue to support the implementation of novel models to estimate the number of infected but not yet diagnosed individuals, an area of research that is still challenged. We also want to investigate linkages and collaborations between HIV testing and hepatitis testing and access to care. And for example, our conference next year will not only focus on HIV, but also on viral hepatitis, as there's much to be learned in those 2 areas that could be synergized by being discussed together. We want to support the international institutions and agencies to increase their engagement. In other words, we want to push on. Therefore, we have done the HIV Testing Week, and I'm sure Brian, he will discuss in more detail exactly what we have planned. Thank you very much.